Good morning, everyone. It's Dr. Charlotte Hodges. I am on my morning walk, and it is actually really nice out this morning. It's a little bit after 7. Besides 100% humidity, I mean, it feels pretty good. So not too bad for an August morning walk. So what I want to talk a little bit about today is a topic that I've discussed before, but I kind of want to take a different approach, and I really want to discuss a little bit about which revision surgery is best for me. I have gotten a lot of questions here recently from patients that I'm seeing in the office as to why they need to select one revision surgery over another, and why would these surgeries even benefit them. And you know, there's a lot of data out there. However, for me in my practice, what I always like to do is marry the medical information with my patient's comfort level, because the reality is, you know, oftentimes patients may end up selecting a procedure that maybe is a little less aggressive, so maybe might not offer as much initial weight loss simply because they feel much more comfortable with it. And that is the surgery that they need to have, because you need to feel comfortable with the surgery that you're having. You need to buy into that particular procedure. And if you end up having a surgery that you just don't feel comfortable with, it's almost like a bad pair of shoes that are a little bit too tight. You're not happy with them. Things always seem to go wrong. So I find that if you have really bought into a particular procedure, then that's really the best procedure for you to go with, as a general rule of thumb. So whenever we're looking at revision surgery, there's a couple of reasons why a patient may end up being a candidate. Number one, are you having surgery for failed weight loss? You just did not get the weight loss that you were expecting or wanting. Or are you also, are you having issues with the actual surgery itself? So yes, maybe you didn't get the weight loss you wanted, or maybe you did, but you now are faced with different health problems such as reflux that just won't go away even with all of the medicines that you can take. Or are you having difficulty swallowing? Are you having frequent vomiting? Crossing the street. It's always so funny whenever I go on these walks, people see me walking with this selfie stick and they kind of give me that wonky eye. So are you just having different complications from your primary surgery, and those need to be corrected? And so these are the two different ideas that I take into account whenever I'm discussing revision surgery with my patients, so that we can try to select, so that we can try to select the very best procedure for you. Because again, for the most part, there really isn't one perfect surgery for any one patient. Now, sometimes there's only one option available to patients, depending on the primary surgery that they had. But again, for the most part, it's going to be, kind of up to the patient, and I'm trying to see what is the best one for them. So let's kind of start from the different types of surgeries that are now performed, and then try to discuss the pros and cons of revisions to these. So in the past, patients had stomach stapling, and I mean the distant past. This was like happening when, like even before I was in medical school. So stomach stapling, or a vertical band gastroplasty, that was like a combination of a permanent band and a stapling along the side of the stomach wall. And it really only offered restriction. It was a purely restrictive procedure. There was the gastric band. There is also the sleeve gastrectomy. These three procedures are all purely restrictive procedures. There is not a malabsorptive component, meaning all we're doing is making your stomach smaller one way or the other. Then of course there is the gastric bypass, and there is the duodenal switch. And here more lately, there have been several reiterations of the duodenal switch. There are some people that will get a single anastomosis duodenal switch. There are people that are getting a mini bypass, which when you hear mini bypass, you think oh, it might not be as aggressive as a bypass, but that's actually probably not a good naming of it, because it's actually like a single anastomosis, gastric bypass, and it is actually a much more aggressive procedure than the gastric bypass. It's a little bit between, outcomes are a little bit between a gastric bypass and a duodenal switch in terms of long-term weight loss. So those are the basic primary procedures that we do. And it might get a little bit noisy. I just have one little block to go on this busy street, and people are starting to get up to get ready for work. So my general rule of thumb is, if you have had a purely restrictive procedure, you need to kick it up, and you need to go to the next step up, and you need to add a procedure that has more restriction and or malabsorption to it. So I think in the literature, and also for myself personally, we've really gotten away from rebanding or trying to do a re-sleeve, because the outcomes are just not there. For instance, now in the past, when patients had bands and they were having issues, I can understand if maybe a port needed to be replaced, or maybe if band tubing had a leak, going in and replacing that. But if somebody has had a band and they had failed weight loss, you don't commit the same sin twice. You don't put in a second band. You just offer the patient another procedure. And what the research shows, and what I've seen clinically, is if somebody's had a previous band, they're going to have a much, much better outcome if they're offered a revisional procedure that includes both restriction and malabsorption. They're just not going to get the weight loss that they want if they go from a band to sleeve. And sometimes that can be a tough discussion that I have with my patients, especially if they just don't feel comfortable with a gastric bypass or a duodenal switch. And again, as long as they know the outcomes and they have good expectations, then I may move forward with a band to sleeve. But I'm doing less and less of those, just because I get very, very frustrated patients whenever they go from a band to sleeve. So now what happens with patients that have had a previous sleeve? I've had several patients ask me, what do you do whenever my sleeve is big? I'm not getting those feelings of restriction, or I never really had good feelings of restriction. I just didn't get the weight loss I wanted. Or maybe I had some good weight loss, but now I have a ton of reflux. And having reflux after a sleeve is not uncommon. Excuse me. So what are you to do now? A patient is simply not going to get the weight loss that they want by simply re-sleeving their sleeve. The reality is even if you have some redundant tissue at the upper portion of your sleeve, because that's typically where it is, or at the bottom portion of the sleeve, you might only really be removing a little bit of stomach. That is not going to be significant enough change in your body to give you any appreciable weight loss. Not only that, now that you have made your sleeve smaller, it's going to increase the pressure in the stomach, and then you're going to be much more prone to having reflux if you weren't already having it. So I do not offer re-sleeves in my practice, and actually in the literature, that is actually not seen as a viable revision operation to offer patients. Now, I will say the caveat to that is, it is not uncommon for me, whenever I'm performing a revision sleeve to duodenal switch, for me to go in and make the patient's sleeve smaller, along with performing the small bowel rearrangement. However, I know that if all I had performed was just if I had only performed the stomach revision, the patient wouldn't have really lost any weight at all. So that's with a sleeve. Now it comes to a gastric bypass. And whenever I think of gastric bypass revisions, I always think of one of the tenants that one of my attendings in residency told me. He said, if you have a procedure and there's 101 ways to fix it. That means there's 101 ways to fix it, and there's not really one way that's going to be superior to all others, because that's why there's 101 ways to fix it. And I kind of feel like that's what a gastric bypass is like. We've been doing the gastric bypass for several decades right now. Some of them were performed open. Now, of course, they're all performed laparoscopically, and there are a vast a wide variety of reasons why these may fail for a patient. Perhaps the pouch was made too big. Perhaps the hookup between the stomach and small bowel is too big. Maybe the small bowel rearrangement is not very aggressive. I've certainly seen patients that have had a very, very short hepatobiliary limb. That's the limb of bowel that carries digestive juice. I've seen patients with a very short alimentary limb. That is the limb of bowel that carries the food. So I think if it could go wrong, I think I've probably seen it. And so because of this, there are several different ways that I have seen in the literature, and also what I offer in my practice, several different ways for you to go about a revision of a gastric bypass. Sometimes this is also determined about what your initial anatomy is. And I'll get into that in just a minute. So whenever you're having a gastric bypass revision, as a general rule of thumb, you can either be offered purely restrictional revision surgery, meaning going in one way or the other to make the pouch smaller, or you're given increased malabsorption, so you're going in to give you a more aggressive small bowel rearrangement, or you're given a combination of the two. Now, in more recent years, there have been a number of endoscopic techniques that have come about for patients to have revision of their stomach pouch. And this is just so that they can have a non-surgical option to make their pouch smaller, to give them more feelings of restriction. Sometimes it's a matter of making the stomach pouch smaller itself through over sewing or staples. Other times it's actually going in through a variety of techniques to make the hookup between the stomach pouch and small bowel smaller. Whenever it comes to rearranging the small bowel, so there has been a great debate as to, do you make the food limb longer or do you make the hepatobiliary limb longer? And for me, what I found in my practice is, if I can, I like to offer the patient revision of their stomach pouch as well as their small bowel. And whenever I'm revising the small bowel, I've certainly seen much better outcomes whenever you make the hepatobiliary limb much, much longer compared to elongating the alimentary limb. Now, sometimes you have to elongate both based on what the patient's initial anatomy was, but you really want to make that digestive juice limb longer for patients to have better outcomes in terms of weight loss. So what do you do whenever a patient comes in and they say, doctor, can you just put a band around my bypass? The answer to that is a resounding no, you cannot. If you have a stomach pouch that's large enough that you can slap a band around, you probably just need to go in surgically and make that pouch just a lot smaller. I certainly wouldn't want to offer my patients a procedure where I know that they're going to have some known complications such as gastric outlet obstruction, so difficulty swallowing, a lot of food intolerance and things like that. And unfortunately, those are the things that we do see with the band. So I would certainly not recommend a banded bypass. And again, in the literature, this has fallen out of favor. The other thing that I have had patients ask me is, can you just go in and sew up my pouch? I'm just not losing the weight that I want. And unfortunately for some patients, if your stomach pouch is already small, so if it's about 35 to 50 mils in volume, there really might not be anything to cut off or to over sew once you put a little measuring device down. And that can be something that's very frustrating for patients, because one of the things that they're seeking is that those initial feelings of restriction that they had whenever they had their original surgery. If I see a patient preoperatively and they essentially have a small pouch, I know that this patient is going to be a bit more frustrated, because I'm probably not going to be able to do much in terms of increased restriction, because they really already have a small pouch, and they're not going to have those same feelings of restriction after their revision. And I think from a psychological standpoint, that can be very frustrating for a patient. They'll almost feel like they really just haven't had anything done, because what they were relying on a lot in the past was those significant feelings of restriction that are telling them, okay, you just need to stop eating. What happens though if a patient has had multiple surgeries? Ooh, there's glare on this, sorry. What happens if patients have had multiple surgeries and there's a tremendous amount of scar tissue in their abdomen? We may find that they're not even a candidate for small bowel rearrangement, or maybe they've had previous surgeries and I'm concerned about the remaining bowel that they will have left. Sometimes the only option is for me to try to do something, albeit it might be very little, to their stomach pouch. However, I will tell you, in those cases, I like to have a very long discussion with the patient so that they have good expectations. And typically those expectations are, you're not going to have significant weight loss. We're definitely going to have to pair this with some medical weight loss techniques. So, in summary, you can see as many different surgeries that are out there. There's also a wide variety of ways to revise these surgeries when they go bad for whatever reason. I do not recommend patients getting the exact same surgery that failed before. So if you have a band, don't get another band. If you have a sleeve, don't go get another sleeve. If typically whenever a patient is having surgery, you want to go to the next step up. So if you've had a purely restrictive procedure, you need to go to a procedure that offers both restriction and malabsorption. There was actually a study that came out last year that was looking at weight loss outcomes for patients that were going from a band bypass, revision of gastric pouch only whenever they had a previous gastric bypass, revision of gastric pouch and elongation of hepatobiliary limb, and then also revision of a vertical band of gastroplasty to a bypass. And what that study showed, and I had a large cohort, about 250 to 300 patients. What that study showed was patients that were given restriction and malabsorption across the board had much better weight loss compared to restriction alone. So for instance, the band to bypass, the Blvd to bypass, and the bypass that had both pouch and limb revision surgery, those all were able to lose more weight compared to pouch revision alone of the gastric bypass. With that being said, that the patient that received pouch revision, they were still able to lose weight. So if you've had a previous bariatric surgery, I encourage you, do your homework. Talk with your different bariatric surgeons. Not all bariatric surgeons perform revisional surgery. One of the discussions that you will be having with them is, what are the problems that you've had in the past? Is it purely weight loss issues, or are you also having some other health problems such as reflux, dysphagia, which is difficulty swallowing, things like that? Because that can also direct the surgeon in terms of which revisional surgery is best for you. Ask them how many procedures that they've done, and ask them if they have why they like one procedure over another. These are all good questions to ask. You can always also just go to my website, and I have a lot of extra additional information about all the different procedures and revisional procedure as well, in terms of percentages and all that good stuff. But please just do a little bit of homework, because just as there are 1,000,001 ways apparently to do revision surgery, there's also 1,000,001 surgeons out there, and I want you to try to find the best surgeon for you that can give you the very best revision surgery possible. So I hope that this has been helpful. This has been, golly, I think one of my longest videos. I've been a little chatty this morning. So give me a thumbs up. Don't forget to subscribe, and please share this with your family or friends or anyone that might be contemplating revisional surgery. There's just a lot of different questions that go into these surgeries, and sometimes just trying to find the best data can be a little difficult. So please feel free to share this. Bye.